morning, everyone. How are you? I just want to say welcome. Thank you for joining us for the first SIR RFS Global Angio Club webinar. My name is Shalwa Adenakinju, and I'm an IR fellow currently at Mount Sinai, New York. I'm currently part of the SIR RFS Vascular Service Line. Although I've had many hats in this organization, my first service line was actually PEDS, so I'm really excited about today because it has a special place in my heart. The SIR RFS, in collaboration with the Society of Interventional Radiology and the Indian Society of Vascular and Interventional Radiology, is very excited to kick off this global endeavor. We hope that it will spark your interest in PEDS interventional radiology and ultimately equip everyone here with the knowledge to further treat our patients in our communities. We have some of the most experienced and enthusiastic international faculty in charge of us today that will be helping us lead and moderate this webinar. We have with us Dr. Patel and Dr. Rush Chewning, each from London and Harvard respectively, who will be our moderators. Today, it's going to be a little bit different since it's Angio Club. We're going to have our presenters be our trainees from all over the world. We have Dr. Ruta Pamadi from Michigan joining us, Dr. Doug Mullahan in London, UK. We have Dr. Tush Garaj from Mumbai, India. Tushar Garj, sorry about that, from Mumbai, India. Dr. Maz Buhari from Harvard Medical College, and also Dr. Ravi Manek, also joining us from India. Now, let's just get into a little bit of housekeeping before we move forward. We have a fantastic agenda. They're all going to give their presentations in the order they were introduced. However, we want this to be an active Angio Club, so your participation is really our priority in this session. Right now, everyone is on mute to avoid any background noises. You can enter a question that you have in the comment box that you'll see in the bottom corner of your screen, and that'll be answered by the faculty. Please do not hesitate to ask any questions, but also don't ask questions in the chat box. That really is a separate function to increase your interaction. A recorded version of this webinar is going to be available at a later date on the SIR RFS IR Educational YouTube channel. And that's pretty much for the housekeeping rules. So without further ado, it's time to turn it over to our wonderful moderators, Dr. Patel and Dr. Chewning. Let's kick this Angio Club off.
Well, I guess good morning, good afternoon, and good evening, depending on where you're logging in from. Prem and I are happy to have you join. Rocky, thanks for organizing and inviting us. We don't want to take up too much of time with introductions, but go ahead and turn it over to our first presenter to get started. And we're happy to answer questions along the way. We will have a period of time for question and answer at the end of each presentation.
All right, so with that, again, good morning, good evening, and maybe good night, depending on where you're joining us. My name is Rudra Pampati. I'm an IR resident at the University of Michigan. You guys can call me Rudy as well. It's a common nickname I got. So I'm going to be presenting a case that we performed last year as endovascular closure of an intrahepatic portosystemic shunt. Just included a big picture here of our campus, our children's hospital. I don't know if you're able to see my mouse, but it's the hospital most left of the screen here. So again, well, I just want to thank the RFS organizers, Indian Society of Vascular and Interventional Radiology, and everybody involved in putting together this really cool global initiative. So with that, I'll jump right in. All right, so no disclosures. I do, however, want to mention that we'll be discussing an FDA-approved medical device, although this is an off-label use of that device. Special thanks to a mentor and the fellow that was involved directly with this case, Dr. Joe, who many of you may know. So our patient, it's a two-year and 5-month-old male who initially presented to an outside hospital after a new onset seizure and altered mental status. So before he was transferred to our pediatric critical care unit, some baseline outside hospital management, he did receive some anti-epileptics and was able to terminate the seizure with fluids and lorazepam. His laboratory values showed mainly borderline elevated AST, ALT, elevated lactate, which you can often see after tonic-clonic seizures, as well as an elevated ammonia. Given his new seizure, the imaging that was performed was a head CT and a brain MRI, both of which came back normal. When he was brought to our pediatric critical care unit, at University of Michigan. He was somewhat known to the Peds GI service. His past medical history included some congenital and developmental abnormalities, including trisomy 21, developmental delay. He did have failure to thrive, ASD, had a diagnosis of celiac disease and GERD. Given that history of GERD, he had also underwent a nascent fundoplication and EGD with biopsy at the age of 1 year and 10 months. Also to mention, so the patient was adopted at 10 months old, originally from Eastern Europe, and at the time he was severely malnourished. At 10 months, he had only weighed about 10 pounds. So he had a lot of chronic issues that were not necessarily being treated effectively, and also as well as some chronic issues since birth. He had unexplained slight borderline elevated liver enzymes and hyperammonemia, as well as chronic vomiting even after his fundoplication that had not really been attributed to anything. So that was kind of his past medical history. So on arrival, in terms of his vital signs, he was tachypnic. Again, his lab showed the same sort of abnormalities as the outside hospital. And given some apparent involvement of his liver function, decided to get a liver ultrasound with Doppler evaluation, which he had not had before. So on ultrasound, we have a sagittal view of the liver. I have the arrowheads here pointing to the portal vein with this, hypoechoic structure here, the extrahepatic portal vein, and then the round structure here in the intrahepatic main portal vein, and then continuing more right laterally, you could see the main portal vein here, and then you could start to see the IVC, and then you could see there's also this connection here between the two structures. On color flow, you could see that the red flow is, indicating the portal venous flow towards the probe, and ideally you would see branching of the right anterior posterior, the anterior and posterior divisions of the right portal vein as well as the left portal vein, but instead you have flow that is going in the opposite direction and into the IVC. Again, just another, this is more of an axial view where the portal vein here, again, you can see this anomalous connection to the IVC. In this color Doppler ultrasound, I just wanted to point out that there was some antegrade flow directed towards the periphery of the liver that was presumed to be some diminutive or atrophic portal venous, intrahepatic portal venous branches. Given that we had this ultrasound finding of an anomalous connection between the portal vein and the IVC, we recommended additional cross-sectional imaging for potential operative or endovascular planning. And you can see here similar findings as to the ultrasound. This is our main portal vein here within the liver, which is hypertrophied. It's really hard to appreciate any intrahepatic portal venous branches, just mainly because of the high flow shunting to the IVC, and showing the shunt in 3 planes, again, to just sort of delineate the anatomy and plan for any potential procedure. The other thing I wanted to point out, so you never had received a CT chest, however, you can always see the lung bases, which are important to note when you're looking at abdominal and pelvic imaging. And if you don't really have a baseline of what the chest of a 2-year and 5-month-old child is, it might be easy to overlook some findings that are sort of near the edges of the field of view. So I just want to show the lung bases. The pulmonary vessels should not be this enlarged, this far into the periphery of the lungs. And patients, whether they're adults or pediatric, who have any kind of hepatocellular disease that may result in shunting from the portal side to the systemic venous side, or in this case, a direct connection. These patients can develop hepatopulmonary syndrome, which contributes to respiratory distress, chronic hypoxemia, which obviously can affect development and growth. And the pathophysiology of hepatopulmonary syndrome is not well understood, but there are essentially 3 contributing factors that are always considered, which is a creation of right to left shunts, dilatation of the pulmonary artery vessels, which result in diffusion limitation, as well as additional pulmonary capillary shunts that result in overall ventilation perfusion mismatch and a return of hypoxemic arterial blood from the pulmonary veins to the heart. So when planning our intervention, our team was consulted for a minimally invasive, potentially endovascular, or minimally invasive and endovascular approach. And some things to consider was this was very high flow, it was large surface area. The connection was about 5 millimeters in diameter. And with that high flow and that size and surface area of the connection, there's high risk of any kind of embolic agent. And also, including that shunt, we would want to avoid narrowing the lumen of the portal vein or the IVC and resulting in some kind of flow disturbance and causing potential thrombus formation. And then also, we didn't really have a great idea of what the intrahepatic portal veins look like, given the shunting. Were they atrophic? Were they absent? Would correcting the shunt cause a rapid increase in portal hypertension? So we kind of had to take all those into consideration. So given the shape of the shunt, we decided to use a Amplatzer PFO occluder, which I included an image here. And the idea was essentially to go through the systemic venous access from a femoral approach and try to land it in that shunt and effectively stop portal to systemic flow with this PFO occluder, just how it's used to stop right atrial to left atrial flow. So I have some still images from our venogram, starting with the top left, going across to the bottom right. It's kind of in sequence. So a couple things: we used a Berenstein catheter to cannulate the intrahepatic portal vein through the shunt. A couple important things I want to note out. So it does look like we are able to fill with a little bit of hefty injection. We can backfill some of these intrahepatic portal vein branches. They're definitely atrophic, but they were present. So closing the shunt seemed feasible in the sense that there would be improved flow to the liver and eventual hypertrophy of these intrahepatic portal vein branches. And then, of course, the connection between the portal vein and the IVC. So these PFO occluders, they require, this size was at 18 millimeter. Each disc side was 18 millimeters in length. And it's recommended for actually PFOs that measure to be 5 millimeters in diameter. An 8 French slightly curved sheath was used to, or was advanced into the shunt. We were unable to really get good purchase with our wire into the SMV or the splenic vein, so we effectively just coiled within this hypertrophied intrahepatic portal vein for stability. And hopefully this video plays well, but effectively, the first portion of the PFO occluder device is deployed, and then the second portion is connected by a screwing mechanism. And after the first disc is deployed, you can pull back until you have some restriction, and that indicates that you're kind of hooked well into the shunt. And then you deploy the second disc, and then you can unscrew the disc. So we had an 18 millimeter disc size delivered through an 8 French curved delivery sheath. And eventually, after some time, once we deployed it, you could see that it sort of realigned here to create a nice occlusion, and we have great flow through our IVC. Just on follow-up, there was an immediate drop in his ammonia. Our procedure was done during this time point between 7.6 and 7.7, and you could see the echogenic occluder here. You can also see that the portal venous flow has now returned to an antegrade direction towards the periphery of the liver. This is a sagittal view again here, showing the occluder. One thing just wanted to note is, because we probably slowed or increased the pressure within the portal vein during that adjustment period, and potentially peri-procedurally, we sort of created a little bit of thrombus here. Not very significant and not very flow limiting in terms of its size. On the 8-month follow-up virtual visit, overall everything seemed to be going great. The patient's family had mentioned his appetite and weight gain had highly improved, his energy had improved, shortness of breath, and then him meeting his milestones. developmentally, and his learning skills had also improved. So it was a great clinical response. And just to sort of, a little bit of teaching in terms of classifying these portosystemic shunts. In our case, we had, a rare anomaly, which is an intrahepatic portal vein, main portal vein to IVC shunt. If you've, started radiology residency, and sometimes you read pediatric x-rays when an umbilical venous catheter is placed from the umbilical vein to the inferior caval atrial junction, it may actually end up in the portal vein through the normal shunting of in fetuses, which is through the patent ductus venosus. And then the aberranthy malformation, where the shunts are extrahepatic. You have your type 1 shunt, where all portal venous flows extrahepatically shunted to the IVC, and the portal vein system intrahepatically is completely not developed. And then type 2, where again, you have an extrahepatic shunt. However, there is an atrophic and diminutive either main portal vein or intrahepatic portal vein. So with that, thank you guys for your time. In light of this being pediatric IR and from Michigan, just want to show off my little baby here, who's happy to be here in Ann Arbor. And if you guys have any questions about adult IR or IR residency, or about our IR program at Michigan, feel free to email me or shoot me a message on Twitter. So thanks, and I think I went a little bit over time, but if anybody has any questions, feel free.
Dr. Patel and Dr. Chewning can take over. It was a fantastic case, I think.
Yeah, awesome presentation, Rudy.
All right, but
could I ask a question?
Yeah.
Rudy, great job. That was a great presentation. So you sort of hinted at this, but you guys chose the Amplatzer PFO occluder. Were there other? I mean, there's lots of different ways to close these, lots of different approaches, and I think we can learn something from all of them. But what was it that led you guys to choose this? Was it the location of the lesion? Was it the size? Was it the morphology? How did you choose this device over a different device?
Yeah, so I think we effectively had a discussion with our pediatric interventional cardiologist. So a couple things. What's the stability of the delivery mechanism? How controlled is it? And then also realizing that oftentimes you would like some control, whether it's on a rail system or you're able to detach or deploy coils. We kind of ruled out any coils just given the size and short distance of the shunt. So effectively, we talked with our pediatric interventional cardiologist, just seeing is this more amenable to a PFO occluder versus a VSD occluder. And I think given sort of the low profile of the atrial discs in the VSD occluder, and specifically the sort of convex shape of the Amplatzer, we figured, and then of course, the sort of multi-step deployment with these Amplatzers, where you're able to position it and then unscrew, ultimately detaching it. That was kind of the main. And then, obviously we always think about what's the access going to be. He's 2 years old, so his vessels are a little bit bigger than some of the neonates, obviously. So 8 French was totally feasible in him. So yeah, that was kind of the discussions that were had.
Thank you very much. A very interesting case. It doesn't look like we have any other questions at the moment come through.
I actually have a quick question. I know with a lot of peds IR, there's a lot of MacGyvering that needs to take place. Are there any instructions for use actual occluders that we have for patients with these portocable shunts, or is it all extrapolating from the cardiac devices?
So my own kind of look or research into this was there are a few scattered case reports of using this device in this setting. Alternatively, there was also surgical ligation of these shunts. I don't think there's a great data on the effective occlusion rate of these shunts using this device. But you know, we've used it in a couple situations where we've had adult fistulas with similar morphology and size, and it does give you a little bit, seems to be when you have such a short distance of a shunt that no coil can sit, and on either end of the shunt the vessels are essentially hypertrophied and really large. It seems to give a good stable occlusion there. So I think it's something that we can use. I don't know if it's going to be coming up frequently enough in any particular situation to have good data, but it definitely seemed to be really, really useful in our situation.
Excellent, thank you.
I think there are non-cardiac detachable plugs that you can use as well. I think you guys made the best choice with what you thought for stability, but if that was what was behind that question, there are other non-cardiac plugs that are designed for the peripheral circulation that could be used. There are various manufacturers, but I think choosing, based on that short kind of segment, choosing a plug that would seat well and be deployed well was the driver, and I think they made a great choice.
All right, well, thank you guys for all your comments and questions.
Thank you very much. We move on to
Please. So next up is Dr. Mulholland from London.
Hi, can you guys hear me okay?
Yes.
Perfect. Okay, so I'll start. See if I can close that. Perfect. So yeah, my name is Doug Mulholland. I am just coming to the end of a year in Guy's and St Thomas's in London, where I've been working as an IR fellow, and part of our job here is to cover the Evelina Children's Hospital, which is a large paediatric facility in central London with interventional radiology cover. So our case is emergency embolization for hemorrhage in a 6-month-old on ECMO. So no disclosures to be made. So the patient was 6 months, of course, and weighing 7.3 kilos. The patient was established on VV ECMO treatment at age 5 months for severe ARD secondary to an adenovirus infection, and had quite a prolonged course on ECMO. And 1 month into his treatment on ECMO, he suffered a cardiac arrest due to a severe line sepsis. At the time of the arrest, a new central venous catheter was inserted through left femoral access. And at the time, the inserting physician noted that this was a difficult puncture. This is the radiograph post-line insertion and after they had achieved ROSC from the arrest. And it shows a line coming in from the left femoral in adequate position. You can see the ECMO cannulae in the right groin and coming in from the right jugular, and a feeding tube present also. So in the 12 hours post-arrest and post-line insertion, the patient developed an enlarging mass in the lower abdomen, and they suffered a hemoglobin drop from 111 to 91 within this time period. A portable ultrasound was requested in ICU, and this showed a 5.5 by 3.9 centimeter heterogeneous mass in the left lower abdomen, consistent with the hematoma. However, the patient did remain hemodynamically stable and was transfused. The anticoagulation for the ECMO unit was suspended temporarily. The patient didn't have any further deterioration and actually remained relatively stable for the next 6 days, but had an ongoing low-grade transfusion requirement. However, on day 7 post-line insertion, the patient developed an acute compartment syndrome. The general surgeons were contacted. The patient had an emergency laparotomy and laparostomy, and a defunctioning stoma was formed. This persisted for 2 days when they had a patient had deemed to be improved enough, and the surgeons closed the abdomen. However, 2 days later, the patient suffered another acute massive intra-abdominal hemorrhage and had a second emergency exploratory laparotomy. The surgeons weren't fully convinced it achieved source control, and the following day the patient had a CT angio. So some images coming in from the left, scrolling up. These are some selected axial images in the arterial phase. Hopefully you can see the blush coming from just adjacent to the left external iliac artery there. And coming back down. So these findings were thought to be suggestive of active bleeding in the region of the left external iliac artery. The patient had another exploratory laparotomy. The surgeons evacuated further hematoma, but again noted it to be very difficult to get adequate source control. And they performed another laparostomy and left some packing material in situ this time. The patient continued to have a low-grade transfusion requirement, so at day 14 they had a second CT. And this showed a pseudoaneurysm from a branch of the left external iliac. So starting from the bottom and scrolling up, these are side-by-side arterial and portal venous phase images. So coming up, and there you can see the aneurysm there with the red arrow noted on it, and no further extravasation on the portal venous phase. This is just a coronal MIP showing that blush from the region noted on the axial images. So at this point, given the multiple laparotomies and the prolonged nature of the presentation, it was decided for a combined procedure between the general surgeons and the interventional radiologists. So the patient was brought into the angio suite. The abdomen was still open at this stage, and you can see from our first screening image here, there's some packing material in the abdomen just over to the left. You can see the ECMO cannula in the right groin here. And what we've done is we have punctured the right common femoral vein, or right common femoral artery rather, adjacent to the ECMO line, and we have achieved wire access up into the aorta. We've gone up and over to the contralateral side using a 4 French burr catheter and parked our catheter in the left common iliac. Our first run, you can see the blush just here coming off that branch, as was noted on CT. Another further magged up view, again trying to open up that vessel, or trying to see closely where that vessel is arising. So we get into that vessel, that supplying vessel, with a 2.7 prograde. Another run there shows the pseudoaneurysm very, very nicely. Then we advance further, we get beyond the pseudoaneurysm and then coil back. So I think we dropped 6 Cook Halal 3mm by 10mm coils, and we tried a run here, but saw we hadn't actually excluded the pseudoaneurysm, so dropped a further 2 coils, and then we were happy we'd excluded at this stage. Further completion run there shows a good result. At this point, the surgeons removed all their packing material, and we did a final aortic run, and we were happy we saw no further active bleeding or pseudoaneurysm. So we used 8 coils in total and deemed this to be a technically successful procedure. Following this, the patient remained on ECMO for 2 further days and then was decannulated. He had a prolonged recovery in ICU and was extubated 1 month post-procedure and was finally discharged home 2 months post-procedure. They're now age 11 months and are well and have recovered from the entire incident. So just a few notes on embolization for hemorrhage in pediatric IR. So pre-procedure planning is everything. So CTA is extremely helpful, and you can do a dual or triple phase, that meaning an arterial and portal venous phase, plus or minus the initial non-con. Discussion from the multidisciplinary team is absolutely essential. So the ICU team, the general surgeons and ourselves were heavily involved in this case. There are some concerns with achieving access, so we are big fans of using the Abacath needle and an 018 nitinol wire to get into these small vessels. Generally use 4 French sheets. Common femoral artery is the access that we most commonly go for, but auxiliary access is also an option. We typically tend to use 4 French catheters with a range of micro catheters depending on the vessel size. We tend to use 014 wires, and in this case we used a Fathom wire with their prograde. For aortography, you can use a pigtail. The pigtail may not form in the aorta, so you can use a burr or a straight catheter with side holes. For going up and over to the contralateral iliac, you could use a short BMC or a burr catheter, and all injections are done by hand. We do hate seeing any sort of blood loss that's unnecessary when performing these procedures. So when we're aspirating and flushing the sheath, we make sure to use only small volumes. We flush the sheath with only small volumes also because we don't want to overload the patients at the same time. And we tend to use Y valves on the back of our catheters to prevent blood from dripping out when there's a wire inside the catheter. In terms of sort of more general concerns, we tend to use 50-50 contrast. We do document the exact volume that's used. Obviously, radiation dose, a much greater concern, so we take all the precautions that you would normally take in order to get the dose down. Just a quick mention in embolization of ECMO patients. These patients tend to be fully anticoagulated. Bleeds whilst on ECMO is actually not uncommon, and the ICU teams can temporarily stop the patient's anticoagulation, but that does run the risk of circuit thrombosis, which is a potentially grave occurrence, so they may need more definitive treatment. Things to bear in mind include the site of the ECMO cannula. So ECMO cannula will commonly will go into the right femoral or common femoral vein, but we have found it's absolutely technically possible to do an ipsilateral arterial growing puncture if you need to. Try and keep the arteriotomy site as small as possible. Closure devices, that's more for adult patients on ECMO, but we just do bear in mind that you may need to re-access and re-embolize these people if they do have a rebleed. So bear that in mind when choosing a closure device, but as I said, that's more in mind for adult patients. When using coils, the ICU teams are often very keen to restart the anticoagulation as soon as possible. However, the patient does need to still be able to clot off to allow the full thrombogenicity of the coils to work. So we generally advise the ICU team to wait approximately 30 minutes from after the last coil has been deployed before restarting anticoagulation. And although this patient had somewhat of a prolonged course, we have found that these patients, it's usually extremely time sensitive. So when the patient is in CT getting their angio, the IR team should be ready to go. We've noted an uptick in embolization in patients on ECMO in the last few months on account of the COVID-19 pandemic. So we have seen it happen. We have done a number of these cases now, but this was the only pediatric case. The rest were all adults. So in conclusion, endovascular embolization is a viable treatment for acute hemorrhage in pediatric patients. Pre-procedure CTA is extremely useful, and there are a number of technical considerations, so it's not just adult IR in little people, and also embolization of patients on ECMO is technically feasible. Just like to acknowledge some of my consultant colleagues, Dr. Anita Parthman, Dr. Usman Raja, who are the lead physician or radiologists on the case, in addition to Dr. Makros. Many thanks to all. Any questions, please direct them to me via email.
Thank you very much, Doug. Really great case, and what seems like an overview of the entirety of pediatric angiography. Just a couple of comments more than questions. You mentioned about using a 4 French sheath, and I know at many institutions people have started to use radial sheaths in the femorals in small children, just because it allows you that 4 French access for a very slightly smaller outer sheath diameter. And I guess you very nicely illustrated the it's one of those rare instances in children where you have a trauma and end up doing an embolization, because most trauma doesn't require intervention. So thank you for that. And I just wanted to reiterate about the closure devices that you mentioned, that you very thoughtfully mentioned that they are predominantly for adults, but there's not much data to support their use in children, especially that sort of small end that you were talking about. And I think the small volume of publications that there are suggest that they're not useful, and certainly within the Society of Pediatric Interventional Radiology, there seems to be an eternal cycle of discussion about closure devices in children, and I think most people favor just compression to achieve closure. So just to reiterate that point. Do we have any questions?
I have a question. I've recently been studying a lot about the NBCA glue, and given this fact that this patient had coagulopathy issues, was there any consideration for not using embolic coils and rather which depend on the coagulative factors and just use glue?
Glue actually wasn't discussed. I think that may have been due to the operators involved. Everyone was just much more comfortable with coils. Can't think of any good reason why we wouldn't have used glue. I think, as I said, it was probably just an operator preference.
I see.
Doug, that was a great presentation. Prem, you mentioned using radial sheaths, which is a great idea in terms of minimizing the size of the hole you're making in the artery. The other thing you can do is if you're planning on not doing a lot of catheter switching and a lot of manipulation, is just forego the use of a sheath and go straight in with your 4 French catheter. It leaves a much smaller hole. Again, if you're switching catheters frequently, you're going to cause a little bit too much trauma potentially, and then the hole ends up even larger than you would have if you had just kind of decided to go with the sheath in the first place. But if you kind of know where you're going, know you're going to have minimal catheter switching, if any, going straight with just the catheter and not a sheath is an option. And that's something in the really tiny kids that we do just to avoid being occlusive in the artery that you do access.
Some people are having issues with that. They cannot see the images. I'm not sure how to resolve that. Ahmad, are you there?
It looks like he said now it's okay that he can't see the images.
Yeah.
All right, sounds good. And there are a couple questions. I think one question in the chat box, it was from Rudy's case, and I would leave that for the moderators to answer. And if you guys are okay, we can move ahead with the next presentation.
So just before we do move on, I don't actually see any questions. I don't know if I've set up.
I can't see any questions either.
So if you go under drop-down menu, on the control panel, it says questions. And in that, it's there are questions. If you don't, then maybe what I'll do is...
I can see that panel, but I don't see anything in it.
All right, give me one quick second.
Does it give you the option to click the actual arrow where it says questions?
See if you can see.
Now I can see something.
If you click the
I can
arrow,
see
it should
them now.
close. Okay, perfect.
Yeah, whatever you just clicked enabled me to see it. Prem, can you see them?
Yeah,
I can now see them, yeah.
I just
Excellent.
made you guys an organizers. Okay, sweet. Next up is Tushar Garg. He's a medical student from Mumbai, KEM Medical College. Take away the stage, Tushar.
Hi, can you hear?
Yes.
Hi. So I'm a 5th year medical student from SAGS Medical College, India. I'm going to present a case of intracranial non-canalic pile arteriovenous fistula. My attending is Dr. Saraf, who did perform the case and helped me with the presentation. I have no disclosures. So the patient is a 2-year-old male child who presented to our hospitals after 6 months of increasing weakness on the left side and an inability to walk. The power was lower distally in the upper limb, and lower limb power was less than 3 by 5. For further evaluation, neuroimaging was done. So on MRI, you could see venous varix in the right frontal lobe with flow voids, which signify hypertrophic arteries. So here you can see the venous varix, which is opening into the superior sagittal sinus, and hypertrophied middle cerebral artery and anterior cerebral artery. On imaging, on MRA, you could see hypertrophy of the MCA and ACA, and on MRV, you can see a fistula, but you can't actually make out if it's a pile AV fistula because the imaging was obtained at an outside center, so the quality of the images were not that good. So after that, we first of all we performed a diagnostic angiogram. So in the ICA angiogram, above is Down's view, and then lateral view, you could see right-sided hypertrophied ACA and MCA, both of which seem to be opening into the fistula, but the ACA is more hypertrophied as compared to the MCA. The dilated venous pouch looks like it's opening into the superior sagittal sinus. So here you can clearly see the anterior cerebral artery is opening into the fistula at the point where the diameter of the ACA increases. That is the point where it opens into the fistula. On the left vertebral artery angiogram, we can see the PCA is actually trying to supply the MCA due to the relative decrease in blood supply of the MCA, which has occurred because the fistula is taking all the blood from the anterior circulation. In the left IC angiogram, there is actually a variation in this patient. The right pericallosal artery is being formed by the bihemispheric left anterior cerebral artery, and that is opening into the fistula. So the treatment plan. In cases of Patel AV fistula, this patient is a case of high flow posterior frontal parasagittal Patel AV fistula, which was first identified on the MRI and then confirmed by DSA. This case is a multiple hole because both the arteries are opening at different locations in the venous pouch, and multiple arteries because you could see two branches of anterior cerebral artery opening into the venous pouch. So that's why it's a complex Patel AV fistula. So the plan was to perform embolization in 2 separate sessions, so that in the first session we could decrease the flow and improve the patient's symptoms, and there is less risk of complications in stepwise procedure. During the first treatment, we first target the maximum hypertrophied artery. So you could see of the 2 arteries, the first one, our target artery is the hypertrophied posterior internal branch of anterior cerebral artery. We went through a femoral access and then took a microcatheter, Apollo detachable tip microcatheter. Then the microcatheter shows the fistula and the blood going into the venous pouch. After that, we injected 80% concentrated glue into the fistula, and as soon as we injected the glue, we pulled out the microcatheter. That's the reason for using the Apollo detachable tip microcatheter, and this formed a sort of a mushroom cast. Then the patient underwent CT scan just after the procedure, so you can see the contrast as well as glue in the venous pouch. Then the next procedure was then planned to target the second hole, which we initially planned 1 month after the procedure, but due to some logistics and payment problems, the patient then came 3 months later. So now when we did the second diagnostic angiogram, the angioanatomy became more clear. So initially we thought the MCA was supplying the Patel AV fistula, but in this you can clearly see that MCA is actually not supplying the fistula. The supply is coming from the right pericallosal branch from the bihemispheric ACA, which can be seen here. I've marked it with an arrow. It's supplying the fistula and opening into the venous pouch, which is draining into the superior sagittal sinus. So here we actually, to confirm that the supply is from the left branch, we took micro catheter injections. Here you can clearly see that the left-sided branch is supplying the fistula. So then the right pericallosal branch from the bihemispheric left ACA was accessed through the microcatheter as the microcatheter chute. Then again, this time we used diluted glue, 30%, and we aimed for complete exclusion of the fistula, and the glue was injected till the whole venous pouch was filled, and then it was pulled out. On the left, after the glue injection, on the left AC angiogram, you can see there is delayed filling of the fistula, for which we did not inject glue again, because most of the times the fistula thromboses itself. So there's the right IC angiogram, which shows there is no filling of the fistula, but there is some perinatal angiopathy, which you can see in the left hand, top left hand corner. After that, the post procedure CT showed glue in the fistula and the venous pouch. So post-operatively, the child actually became drowsy, and there was increased weakness of the left side. So for which we performed a repeat CT scan, which showed bleeding from the perinatal angiopathy, which could be seen on the right IC angiogram. So for this, we just performed anti-edema measures, and we actually saw gradual improvement in the next week. At discharge, the patient was conscious, alert, he had normal speech, and the left upper limb and lower limb power was 3/5. On 1 month follow-up, there was marked improvement in power, and the patient could actually walk without support. So then we performed a controlled ESA after 6 months. Here you can see there's complete exclusion of the fistula, and there is no filling. So some basics about Patel AV fistula. So Patel AV fistula is a rare congenital direct arteriovenous shunt without a nidus, which differentiates it from an arteriovenous malformation. There are less than 120 reported cases in the English literature. Patel artery or arteries communicate directly with the vein without an intervening nidus. If these were dural arteries, it would be a dural arteriovenous fistula. These shunts are located in the subpial space, which have an effect on the venous and CSF drainage, that is why these patients can develop increased intracranial raised ICT and hydrovenous disorders. These patients, Patel AV fistula may be seen, multiple Patel AV fistulas may be seen in patients with hereditary HHT syndrome. So the clinical manifestations are usually due to three things: either raised intracranial tension, or the mass effect, or steel phenomena, which was seen in our patient because the blood supply was mainly going into the shunt. There was that is why the patient developed a focal neurological deficit from the MCA supply. So the natural history in these patients is very poor, with mortality reaching 63% if they are left untreated. Hence, treatment is mandatory. So for imaging, DSA is gold standard, and you can see rapid circulation, enlarged feeding artery, and direct filling into the varix. On angiographic analysis, you see the change in caliber of the artery. You can see venous ectasias or pouches, venous congestion. These patients may have associated dural sinus malformations or jugular dematuration or venous stenosis. For basic classification of Patel AVFs, either they're simple or complex. Simple Patel AVFs have a single hole, either a single artery opens into that hole, or two arteries open in, or multiple arteries can open into that hole. For complex Patel AV fistula, there are multiple arteries opening into multiple holes with a single vein in all of them. So management is mainly endovascular. There are a lot of reports of surgical, combined or radiosurgical, but now due to new devices, the management is mainly endovascular. So in cases of simple Patel fistulas, the goal is to plug the hole where the artery communicates with the vein. But in cases of complex Patel AVFs, we start with the most proximal hole and then try to get the whole vein, which we did in our case. The embolic agents, so you can use glue, onyx, or coils. We preferred glue due to its dispersibility and more experience with glue. However, now onyx is being preferred, and a lot of cases are being done with onyx. Coils can be used to decrease the flow and can be combined with liquid embolic agents. For flow control, we can also use balloons. So in conclusion, Patel AVFs are rare intracranial vascular shunts which needs aggressive treatment. So the gold standard for diagnosis is a DSA, and detailed analysis of fistula is important to come up with a treatment plan. Thank you. If you have any questions.
Doesn't look like there are any questions typed. I was just, you covered the only question I had at the end of your talk, which was really how you made that choice between glue and onyx. But I think you said that it was operator preference.
Yeah.
But I note you used a concentrated glue in the initial embolization, and maybe just to highlight that was probably related to the fact that you wanted a rapid closure due to the high flow nature of it, and that's why you went 80%. And the only other comment I was going to ask is that did you opacify the glue with anything?
Oh, actually no. As far as
Sorry, I couldn't hear.
no, I don't think so.
So you just use some Lepiodol or something?
Yeah.
Yeah, I think I will fully disclose that I'm not a neuro person, but I know I speak regularly with our interventional neuroradiologist, and I think he's convinced me that closing down the venous side in the brain, unlike in the periphery, is a little bit, I mean, sometimes you have to do it, you don't have another choice, but it's a little bit riskier in that you can change the venous pressure, and brain is very sensitive to that in terms of its drainage. So you can actually lead to a venous hemorrhage, which may or may not have been what your patient experienced. When you close down the vein and close down drainage, the brain doesn't adapt quite as quickly as other areas of the body, or doesn't tolerate it as much. So I think if there is the potential, due to those connections that you showed of closing down the arterial side, either with small coils or onyx, I think that's his preference, just to avoid the risk of the venous hypertension leading to hemorrhage. But if that's your only choice to shut it down and your only choice to save the child's life, then you have to kind of take that risk. And I'm glad the patient was able to recover from it.
I agree. Thank you.
Okay, so the first presentations all have a theme of closing things that shouldn't be open. So we're going to shift now to opening something that shouldn't be closed. Maz, go ahead.
Thank you, Rush, and a very good morning to all my interventional colleagues across the globe. And I just want to confirm you can see my screen as isn't in a presentation mode.
Yes.
Yep, looks good.
Awesome. So today I'll be talking about, as Rush said, opening up things that are closed, and it is about a revascularization of a acute mesogonadal shunt thrombosis. Disclosures, we don't have any disclosures. However, I have to point that we will be talking about penumbra mechanical thrombectomy device. It is one of the devices that's been approved by our institution. And personal thanks to my mentor, Dr. Rush Chewning, and the SIR Global Angio Club for organizing this awesome meeting. So this is an interesting story of a 17-year-old male with a background history of ulcerative colitis, status post colectomy, and a J pouch. He had a long time story of recurrent hematemesis and had underwent TIPS at an outside hospital, which thrombosed. And subsequently, his portal vein and SMV also thrombosed at an outside hospital. So when he was transferred to our institution, a decision was made to undergo a right mesogonadal shunt in November. And just to give a little heads up on the mesogonadal shunt, this is another form of creating a portal systemic shunt, especially so in cases of extrahepatic portal vein thrombosis. And in this particular case, we use the right side. There's also a literature that talks about the left side. So we use the gonadal vein and we anastomose to a branch of the SMV, so that the blood gets shunted, the arrow from here to there. So 6 months later, this patient presents with high fevers and raised white cell counts. So to go further into the case, I'm just going to go into a little bit of a flashback and say, what did this shunt look like before? So this is just a CT scan, which shows the occluded TIPS shunt, lots of varices, and then that's the shunt. It has some measurements on it. This was the right mesogonadal shunt, which was patent 6 months ago. Same thing on the MIPS. Excuse me for that. That's the shunt there. So when he presented with high fevers and raised inflammatory markers in our institution, he underwent a routine portal venous phase scan, and the scan showed a couple of findings. Although it was not a dedicated angiogram, again, we can see the occluded tip shunt. But if you look at the SMV and its territory, there was poor opacification of the SMV and its branches and the collaterals. And the mesogonadal shunt that we saw beautifully earlier, we can hardly see any opacification at all. So a suspicion was raised for an occluded shunt, and this patient underwent a dedicated angiogram. So I'm just going to move this window for a second. So this was a dedicated angiogram. Although this is an arterial phase, but I think it gives off some information as well. So you can see again an occluded TIPS shunt, and there you can see an occluded. Yeah, all that was occluded mesogonadal shunt. So the same thing on here. That was the occluded mesogonadal shunt. So the next day we decided to do a venogram and angioplasty. That was planned. So we had a right common femoral vein access, managed to get the C2 catheter, and initially on at the level managed to just get into the orifice, but had a huge trouble trying to pass the catheter into the shunt. Numerous catheters and guide wires were tried for a long period of time. It was a very difficult cannulation with repeated dislodgement of the catheter. After several attempts, finally we managed to hook a C2 glide cath for French over a 035 wire, and contrast was injected, which you can see an occluded shunt. Nothing is literally passing through. So at this point, we tried to see if we could exchange the C2 catheter with a 4 French by 90 centimeter fused lysis catheter. And even with multiple attempts, we were unsuccessful. So finally, we decided to infuse a TPA through the existing C2 catheter itself. And the tip of the catheter was left as distally as possible in the shunt. And we, in our hospital, we used a TPA. So this is just a final angiogram, and we placed it. We managed to place the C2 catheter as distal part of the shunt as possible. We can see there is still some diffuse flow distally, and we used a TPA infusion of 1 milligram an hour, infusing through the catheter. Also, we used heparin 500 units, at 5 ml an hour through the sheet to make sure that the sheet doesn't get occluded. And the goal in our hospital is that we monitor fibrinogen every 4 to 6 hours. If the fibrinogen falls below 150, then we cut the TPA into half. And if it falls below 100, then we stop. So the next day, he was brought in for a repeat venogram. And this was the initial venogram. As you can see that the catheter, which was way down here, has been pulled back. So there was a retraction of the indwelling thrombolysis catheter. And also the venography shows there is some minimal flow, but not completely. And there is still a lot of clot burden. So at this point, we changed the game of plan. So keeping this catheter, we decided to come from the right IJV. And it was much more easier access. We managed to get through, and we did not take this catheter out, but instead use it as a kind of a roadmap, a guide to see where we could place our catheter. And then first we started with a 5 French wort, which eventually we exchanged it to 5 French Compi, 65 centimeter. And then these are still images, yeah. And this is the venogram. And then we, give me a minute. And then we exchanged this over the wire to a unifuse lysis catheter. And as you can see, this is the placement of the catheter. And the tip of the catheter was as distally possible in the left upper quadrant, and the proximal part of the catheter was at the level of the anastomosis. And this is a venogram which shows that although there is some opening of the catheter, some opening of the mesogonadal shunt, but there is still a significant amount of clot burden, especially in the proximal aspect with stenosis. So we decided to keep this catheter and go with another day of thrombolysis. And on the 4th day, this is the initial venogram, which shows that the mesogonadal shunt is opening up, but not completely. So what we decided was at this point to have a suction thrombectomy, use a suction thrombectomy device like penumbra, and perform an angioplasty. So we passed the suction thrombectomy device here at this point. We exchanged the unifuse lysis catheter to the catheter Cat 8 for a penumbra device, and we try to pass it as distally as we can, and intermittently we were doing the venograms and with balloon angioplasties. And we used an Indigo Cat 8 system catheter here. And this is again interval venograms as we are progressing through the procedure. As you can see, it is starting to open up and with good distal flow. And then the final venogram shows that we were technically successful in thrombectomy and with angioplasty of the shunt with near complete resolution of the thrombus with marked improvement in the flow. I'll just play this again. So compared to where we started, this was a very good technical success according to us. So talk a little bit about the penumbra system. As I said, we don't advocate this marketing of this product, but however, this is our product that we use in our institution. There are lots of products available which can be used according to your discretion. So This uses a coring technique, essentially meaning that it acts like a vacuum cleaner with a pressure of 98.2 kilopascals of suction pressure. This is just in a simulated vessel. This is how it works, but in real life, this is what we would do. And this is especially useful for removal of fresh soft thrombus with continuous aspiration. And this category 8 and cat 3 to cat 8 catheters, according to the industry, they claim that they have the ability to break the resistant clot within them. To give a synapse, so in the US, there are like 33 approved devices. You can choose whichever you want. There is, of course, Penumbra, and there's also like AngioJet. I'm sure people in different institutions have different experience, and we respect that. And after, on the day 8, we decided to bring him for a follow-up ultrasound scan. These are stat images. As you can see, there is a good persistent flow within the shunt on both color and spectral Doppler. So key learning points, mesogonadal shunts are one of the couple of two novel surgical techniques for extrahepatic portal vein thrombosis, as I mentioned in the beginning of my talk, and they're especially useful for management of hematemesis secondary to portal hypertension. They do have a role in the non-surgical and non-TIPS candidates, and sometimes they do act as a bridge to transplantation. Etiology for occlusion of these shunts is just similar to what you would find in an acute portal vein thrombosis. And the key mantra of treatment is early revascularization. It's totally fine which technique you use, either anticoagulation, thrombectomy, thromboaspiration, or thrombolysis, but it has to be quick. It has to be within certain time. And literature does talk about that the earlier you intervene, the earlier successful you are going to be. So what is the take-home message? What have we learned from this interesting case? Number one, to start with, I showed you a diagnostic scan which was done on a portal venous space. The diagnostic radiologists, kudos to them, they picked it up very well, and you need to have a high suspicion for thrombosis in these patients. Sometimes the way pediatric population is, sometimes you ask for an arterial phase, you get portal venous phase, sometimes you get mixed phase. We have wide variety of experience, and I'm sure people involved in the pediatric world would acknowledge that. So we need to have a high suspicion for thrombosis in these cases. And once we find, then we have to do early appropriate imaging, proper angiogram, dedicated angiogram, or either through the CT followed by a conventional angiogram, and intervention is the key. And there is nothing like one-stop solution. Just because you fail on the first attempt doesn't mean that we have to give up. Sometimes a staged procedure is also an option. And sometimes, you know, we have to come back more than two times. Like here, we came back on the 4th day where we started the actual suctioning the clot. And choose a safe and easy access. Sometimes the first access you get may not be the best access, so planning is the key. And last but not the least, choose a thrombectomy device that you are comfortable with. No matter what the industry people say, no matter what we hear, it's ultimately you have to be comfortable with using the device. So with that, I conclude. Thank you very much.
Thank you very much, Maz. There was just a couple of questions, both from Dr. Vimal Chakau. I'm just going to paraphrase, but Dr. Vimal Chakau was just asking whether you considered opening the tips at any point, and also whether you considered using the angioplasty earlier than day 4.
Yeah, so I will jump in. Miles, great job. So this was actually my case. It came to me very late on a Friday night. We started the case around 8 p.m., which meant limited resources and limited teams. So the tips had been placed at an outside hospital many years earlier and had thrombosed actually over 3 years prior. The team at the outside hospital actually went in and tried to reopen it, and they were unsuccessful. So That had been down kind of chronically for 3 years before he came to our hospital, and that's why our surgeons decided to do a mesogonadal shunt at that point, and the patient had done well with the mesogonadal shunt. That was something that we talked about. Had we been unsuccessful in reopening the mesogonadal shunt, that was going to be the next possible move, was to reattempt reopening the tips, but that's a great question. The other thing is, I will admit that I was in some ways a little too locked into my femoral access from the first night. I had been trained in an institution where we always used femoral access for any thrombolysis, with the thought that patients would prefer to be in a stretcher with a catheter in their femoral vein rather than a catheter in their neck. And so that was my bias going into the case, and I struggled and was a little bit of a victim of my own success. I was 5 minutes from giving up and trying IJ access the first night, Friday night, but then all of a sudden I finally got my wire to go. And I honestly just became overly committed to it once I got the wire to go, even though the angles were not super helpful thrombolysis catheter. So I could.
I don't think my screen is visible. Is my screen visible?
Yeah, can you mute your microphone for a minute, please? Thank you. So the first night, late Friday night. So the day 1 is Friday. Day 4 we're calling Monday. So Monday morning is when we actually went and did the suction thrombectomy and angioplasty of the stenosis. So part of the reasoning was why it took so long is I couldn't get a thrombolysis infusion catheter because it was too stiff to track around that 180-degree bend off of the IVC. So I just left an end hole catheter, the C2 catheter, because that was the only thing I could get to track out there. And quite frankly, the first night it just retracted and didn't do anything to soften the clot. The clot was quite hard. So then it wasn't until, and the patient was not asleep on Saturday when we did the check. We did not have anesthesia support, and we didn't feel like it was appropriate to get new access that Saturday. He was not NPO. So Sunday, we brought him back with anesthesia support, came from above, actually placed the thrombolysis catheter. So in some senses, day 3 was actually the first real day of thrombolysis. So that overnight, Sunday night, the clot did soften a lot, and then we did our work Monday morning. But I think the lesson I learned was, trust your gut instinct, and if something doesn't feel right, switch and make it better. If you're not happy with your access, if you're not happy with the way things are going, just bite the bullet and do it. The other thing I learned is, despite what I had been taught and what I believed, I actually asked this patient, because he was a patient who had both femoral access for 2 days and IJ access for 2 days. And I said, which one was better for you? Which one was more comfortable? And without hesitating at all, he said, oh, the neck by far was better. And so that kind of changed my mentality. Most people don't want to have something, at least I thought most people wouldn't want to have something coming out of their neck. But he was like, this was much better, much more comfortable. And so I just kind of learned, and I think that's going to affect how I do things going forward. Sorry, I just hijacked all the questions. But, any other comments or questions there?
Dr. Chewning, it looks like there's a couple questions in the chat box. What was the dose of the TPA used? Did you use a weight-based protocol or just a standard 0.5 or 1 milligram alteplase or urokinase? And then the other thing was, what did you use to monitor besides fibrinogen? Did you check CBCs and other things? And the last question was the follow-up anticoagulation plan for the patient, if there was one.
Yeah, so those are all great questions. So he's a bigger kid, so we were in a range where we could use the standard adult dose. So we just did 1 milligram per hour. In our smaller kids, we do a weight-based protocol. We check, depending on what floor they go to, which ICU they're in, it's either Q4 or Q6 labs. And we check CBC and fibrinogen. And if they're on a higher dose of heparin, which we use a very, very low dose of heparin, I know that's controversial. They also check coagulation factors, but we don't typically follow those. We check CBCs to monitor for platelets and blood drop or hemoglobin drops, and then we check fibrinogen, which really drives our dosing, and then the anticoagulation plan long term. In our institution, our hematologists like low molecular weight heparin, and so they put him on low molecular weight heparin for a long time.
Great, thank you. And then going back to your said low dose heparin, you use a subtherapeutic dose through the sidearm of the sheath at some fixed rate.
So go ahead, Maz. Oh, Maz, your mic's muted.
Sorry, I didn't want to interrupt when you were speaking. So we use IV heparin 500 units and where there's separate access sheet. The whole idea is to keep the sheet open so that we don't have any in-sheet clotting or thrombosis.
So there are institutions that do full systemic heparinization in addition to the TPA, but we do not. We do the full TPA dose and we just do a very, very low dose heparin. But I know that there's variability in practice across institutions with respect to that.
Thank you for answering those questions, and great case.
Thank you.
Thank you. This was again a wonderful presentation of patience, perseverance, resilience, everything that you need and take care of people. With that, moving forward, last but not the least, we have Dr. Manek from Kokilaben Dhirubhai Ambani Hospital in Mumbai. Take away the stage, sir.
Yeah. Hi, this is Dr. Ravi Manek from Kokilaben Dhirubhai Ambani Hospital, Mumbai. I'm a fellow in neuro and vascular intervention radiology under the mentorship of Dr. Vimal Someshwar and Dr. Manish Srivastava. Thanks to the Global Angio Club for giving me an opportunity to present here. Today, I'll be just discussing a case of renal FMD, which we had done at our center recently. This is a case of a 4-year-old male who in 2013 was presented with uncontrolled hypertension, and the laboratory investigations were normal. The patient was referred to other center, and this first intervention was performed at other center, not at our center. So in this angiogram, this aortogram, we can see that there is tight stenosis of left renal artery just beyond its origin up to the midsection. And similarly, if we see the right angiogram, here also the renal artery appears to be stenotic in nature. So at the other center, what they tried to do was they took a 014 wire, negotiated it across the stenotic segment, and balloon dilated it. Once after balloon dilated it, here we can see that there was a tight waist seen at the balloon dilation part. Post dilatation run shows that there was a revascularization, but along with revascularization, we can still see the stenotic segment in this section. So they went ahead and did a repeated plasty. Even in repeated plasty, there was a waist, and post angiogram, there was a total occlusion of the renal vessel, you can say. So the next step they chose was to dilate the vessel using a balloon mounted stent. In this case, where they have used the balloon mounted stent, previous angiogram, the DSA which we see, we can see that the stent has opened up, but the stenotic segment hasn't well opened up. Here it is very, very, very tight. But at the end, the final angiogram did show good flow into the renal vessels. So they left it that way. Now the question is, was it right to use the stent to open an renal FMD? The question was that either what we should have done was, we should have pre-dilated it at high pressure using high pressure balloons, because usually the radial strength of the stent is not sufficient to open the vessels. And ultimately, at the end, the patient underwent left renal nephrectomy. In 2017, he was referred to us for the same with left renal angioplasty stent failure and hypertension. That time, when we did the angiogram, we could see the stenotic segment in the right kidney, and we did a cutting balloon, and post cutting balloon angiogram showed good revascularization. Now the thing to be kept in our mind is that already the left side has already been nephrectomied, and now we cannot make the same mistakes in the right side. So the difference between a stenotic segment and FMD is that if it is a stenotic segment, you can see certain what do you say, calcification or something. But in FMD, the stent does not work. So in 2019, the patient again presented to us with uncontrolled hypertension of 160/80 mm Hg and right renal artery color Doppler showed tight stenosis. Aortogram again showed right renal artery stenosis, which was negotiated using 014 Fielder FC wire, over which we used OPN NC transluminal high pressure balloon, and we plastered it for around like 10 minutes at a high atmospheric pressure of 38 minutes. Here I would specifically like to mention about this high pressure twin layered balloon construction with a high burst pressure of 35 atmospheres. We went beyond the high burst pressure and we did the inflate till about like 38 atmospheres. Post 38 atmospheres inflation angiogram also shows slightly stenotic segment. We were not happy with the dilatation. So then we used a cutting balloon. That was a Flexton cutting balloon. It was 3.5 by 6 cutting balloon. And we balloon dilated it for around like 10 minutes. Post cutting balloon angiogram showed a leak. So after here we can see that after using the cutting balloon, there was a leak from the renal vessel. So then after that, we again balloon dilated it at a low pressure using 3.5 into 20 mm balloon to tamponade. And the final angiogram, which we did, shows good vascularization with good caliber of renal vessel. And current 2020 follow-up of the patient is BP is normal, like around 120/70 mm Hg, and but currently the patient is on Nicard 10 mg and Ecosprin 75 mg taking alternate days. The lesson learned here, the FMD is classified in 3 types basically in pathological view. That is, it affects all the 3 layers of the vessel, intima, media, as well as adventitia. Whereas when we do an angiographic run, angiographically DSA, by DSA we can classify it in 2 types, that is focal and multifocal. In focal, just there is a tight stenosis, nothing else can help us in that. Whereas in multifocal, it has a grape-like appearance in that. The best treatment options available here is to use a cutting balloon and a high pressure balloon, and to avoid the stent as because when we use the stent, the radial pressure of the stent is not enough to open the stenotic segment. Yes, by using the cutting balloons and the high pressure balloon, there is definitely the risk of vessel getting ruptured or dissected. As in our case, it got ruptured, but we can again achieve tamponade by balloon dilating it. These are certain studies published by people, which data we have it from 1983 till 2008, which shows that about 75% of the patients recovered or cured, improved or cured after using balloon angioplasty in fibromuscular dysplasia. That is an R patient which we did had been categorized into improved because after procedure he was on antihypertensive drugs. The negative prognostic factors in this case would have been long-standing essential hypertension, associated diseases like diabetes and atherosclerosis, long-standing renal dysfunction, bilateral renal artery stenosis as it was in our case, and kidney size less than 8 centimeters and serum creatinine less than 3 to 4. And this about the types of FMDs as we discussed earlier. Angiogram is the final choice which confirms it's a gold standard which confirms the diagnosis, and PTA is a choice of treatment for FMDs and not the stent, balloon mounted stents, and surgery is always an option. Thank you. Thank you. We are open for questions.
Thank you very much. Interesting, another interesting talk. So we've got a question about cutting balloon being better than high pressure balloon from Dr. Vimal Chacko, and what are your thoughts on that?
Sorry, I didn't hear you.
Is a cutting balloon better than a high pressure balloon for FMD? What's the question?
Yes, cutting balloon is always helpful, but our first choice should always be a high pressure balloon, and we should balloon dilate it multiple times. Even after using a high pressure balloon, if we are not satisfied with the final angiogram, then I think that we should go ahead with the cutting balloon.
So much of that data that you showed was derived from adult FMD. I think actually all of those papers were, and I think that we need to be careful. So I think you commented on whether a stent is a good option, and much of the data in pediatrics shows that
Yes, right.
if you do
Right.
stent a renal artery, you end up coming back more often and earlier to re-intervene than if you do not stent it. With
Exactly, yes.
pediatric renovascular disease, there is a belief that there is a process of remodeling which has to occur. So coming back at repeated intervals to angioplasty those vessels is thought to be useful and achieve a good result. I don't believe there is any good literature supporting cutting balloons for children over any different type of balloon. And Rush, you can correct me if I'm wrong, but when I last looked, I know at CHOP, which is a big institution that has a big renovascular practice, they favor use of cutting balloons, but haven't published their series yet. But I think are in the process of. At our institution, we do use cutting balloons, but would favor repeated angioplasty and cutting balloon only for those recalcitrant stenosis that you cannot open with a conventional or high pressure balloon. Yes, I think we
Exactly,
think along
sir. As
similar
in
lines.
our case, yes, sir. Exactly. In our case, like we initially used the high pressure balloon. We did plasty for multiple times, but the final angiogram was not that convincing. And considering the age of the kid, and this was not the first episode that he was undergoing the angioplasty. So then finally we decided to do the cutting balloon.
Yeah.
And do you think the cutting balloon increases the risk for dissection and rupture?
Sorry, I didn't hear you.
Do you think that the cutting balloon increases the risk for dissection and rupture?
I personally feel that along with you use cutting balloon as well as even if we use high pressure balloons, the chances of rupture and dissection almost remains the same. But yes, the chances of rupture and dissection does increase by the use of cutting balloons.
I was just going to ask about the kidney that went in the bin, the left nephrectomy. Was,
yes, sir.
I guess not really an interventional radiology question, but was there not a consideration to auto transplant that kidney?
Sorry, I didn't hear you, sir.
Was auto transplantation of the left-sided kidney with the failed stent considered?
Sir, actually we don't know, because by the time the patient was approached to us, already the nephrectomy had happened. The first angiogram that we seen was not at our center, it was done at some other center, and then post nephrectomy the patient was referred to us for the second kidney.
Okay, good. So surgery, in our experience, surgery is not often used for these patients,
not
but
often used.
as a
Yes,
bailout for failed intervention, an auto transplant is often used.
That is fantastic. Thank you so much for wonderful this. With that, we have completed all our presentations. The floor can be open. We still have like few minutes, maybe 5 minutes left. If anybody has questions, or Dr. Chewning and Dr. Patel can take over and just do the closing remarks.
Sorry, I was just typing, adding to some of the questions that are being typed in. To the 5 who presented, thank you all again for your time and effort in putting together these great cases, and I think we've all learned a lot from them. So thank you for great presentations and for sharing. And for those who participated, the questions both verbally and on the type box were fantastic and helped kind of bring out specific points. So thank you all for your participation.
Thank you very much to all the speakers.
For coming again. We will probably have another Global Angio Club meeting in about 10 weeks for peripheral arterial disease and aortoiliac disease. We'll be sending out another invite, and if you haven't followed on Twitter, follow us on Twitter, and we can send out those links at that time.
I just want to address one more thing. Sorry, I'm looking in the questions box. Murphy had a great point discussing suboptimal angiographic pictures does not really predict suboptimal clinical result. At our institution, when we're doing renal interventions, really mostly with most stenoses that are visceral, we measure pressure gradients. So that could be something that could be also, you can use in your toolbox if you're still seeing a mild narrowing. However, the pressure gradient, there is none. You might be able to safely say that you are complete with the procedure. I don't know what the panelists think about that.
I was kind of alluding to that when I was talking about remodeling at our institution. We don't chase an angiographic result for sure, and I think most people consider pediatric, in pediatric renal arteries, FMDs, an unusual disease in the way it responds to angioplasty. And I think what you need to do is do an angioplasty, and it may not look great on table, but you will have caused some endothelial and deeper damage, and it will remodel, and hopefully will remodel to a better configuration. And I think that's the other point Murthy was making, which is what I said earlier, was that it's a process of remodeling. That's why repeated angioplasty is often a useful tool. It's a different beast to an acquired stenosis.
I think Prem, you have more experience with this than I do, but I think we have a tendency to think of the patient as on our table as this is the only time I'm going to see this patient. And so you kind of maximize and maybe push a little too hard or go a little too far. But I think in this particular entity, these are patients that are going to come back more than one time. And so I think, sort of like some of the vascular anomalies patients, you do as much as you can, but don't push too far, and then re-intervene when necessary, because these are people that are going to come back multiple times usually. So I think in some ways less is more, and yeah, and that less is more. I'll take my own advice and stop talking.
Well, we learned a lot today, and thank you to each and every single presenter, and a big thanks to Dr. Patel and Dr. Chewning for agreeing to be wonderful moderators today. We will be looking forward to your association soon when we have our next Angio Club, and again, we will have trainee presenters. This initiative is started by trainees and will be for trainees with the help of some of the amazing attendings. So with that being said, thank you everybody. We are gonna close for today, and look forward to seeing you again next time.
Thanks so much, everyone. Great job.